Welcome to today's deep dive. We're unpacking a really deeply misunderstood medical and psychological intersection today.
Yeah, it's a tough one. We are looking at what happens when your physical pain is entirely real, but, every single diagnostic test comes back completely normal.
Right. And to explore this, we are looking at the clinical and operational model of coping and healing counseling, or CHC. They're a telehealth therapy practice based out of Georgia.
And their approach provides a really clear window into how modern, accessible care models are trying to fix just a massive gap in the healthcare system.
Yeah, to start, picture this scenario. You've been waiting weeks, maybe even, I don't know, months for a specialist appointment.
Oh, absolutely.
You were sitting in a freezing cold exam room, wearing one of those crinkly paper gowns,
hmm
and you're just desperate for an answer to the very real pain you are feeling every single day.
The anticipation in that specific room, under those harsh fluorescent lights, it is completely exhausting for a patient who is already running on empty.
Definitely. And you finally get the doctor in the room. They've run the blood panels. They've done the really expensive imaging. And the doctor looks down at their tablet, sighs, and says, well, the tests all came back normal, so it must just be all in your head.
Ugh, the worst thing you could hear.
Okay, let's unpack this. Because when a doctor delivers that specific phrase, they might actually think they're delivering good news.
Right, like, hey, great news, you don't have a tumor.
Exactly. But to the patient, it feels like a profound betrayal. I mean, it feels like the medical professional is looking them right in the eye and calling them a liar.
Yeah, and the damage happening in that exact moment goes far beyond just a bruised ego or momentary frustration. It is a
Oh,
clinical fracture.
clinical fracture. I like that term.
Because when a patient internalizes that their medical team doesn't actually believe them, they just stop trusting the medical system altogether.
Which is incredibly dangerous.
It is. And CHC's entire clinical philosophy is really built around countering this specific moment. Their framework is based on the idea that patients deserve to be believed A&D helped.
That "and" is doing a massive amount of heavy lifting there.
Oh, totally. Believing the patient means actively validating the physical pain, and helping them means introducing them to a very specific condition that bridges the gap between, biological reality and psychological distress.
Which is known as somatic symptom disorder, right? Yeah.
Exactly. Somatic symptom disorder.
So to really understand why a normal MRI doesn't mean the patient is perfectly healthy, we have to look at how a practice like CHC actually defines this disorder clinically.
Yeah, let's break down the symptoms. The primary factor is real distressing physical symptoms.
We're talking about genuine, localized physical pain, or profound bone-deep fatigue, or severe stomach trouble.
Right, but then layered on top of that physical reality is the psychological component.
Right, the worry.
Exactly. The patient experiences just a disproportionate amount of worry, and they are spending a massive, almost all-consuming amount of time and energy fixating on these health concerns.
We really have to completely reframe how Western medicine typically views the mind-body connection here, don't we?
We do, because the core truth of somatic symptom disorder, and I'd say the single most crucial takeaway from CHC's clinical approach, is that these physical symptoms are genuinely felt.
They are faking it.
Not at all. The stomach trouble is a real biological event happening in the gut. The pain receptors are actively firing. The fatigue is a true physiological reality.
So the patient is not faking it to get attention, and they're not imagining the sensation.
Exactly.
Let me see if I can translate this mechanically. Is this sort of like a car's check engine light coming on when the engine itself is mechanically flawless, but the actual sensor system is trapped in a false alarm state?
Oh, that is a great way to put it.
Because even if the transmission isn't actually falling out of the car, that blinding red light on the dashboard is still very, very real to the person driving. I mean, it's piercing their vision and ruining the whole drive.
Yeah, the sensor system being trapped in an alarm state perfectly captures the biology of what is happening here. The human nervous system is incredibly complex.
Right.
And in the case of somatic symptom disorder, it is essentially misinterpreting or dramatically amplifying normal physiological signals.
So the brain is processing everyday bodily functions, or just minor discomforts, as catastrophic five-alarm emergencies.
Exactly. The dashboard light is blinding, and the driver is reacting accordingly.
But, putting myself in the shoes of a patient who's been suffering for months, I think I would aggressively push back on this diagnosis.
Oh, most people do.
Right. Let's say I finally get told I have somatic symptom disorder. Accepting a diagnosis that attaches a psychological label to a physical pain seems, well, incredibly difficult to do without feeling accused of fabricating the whole thing.
It feels dismissive.
Yeah. Even using the check engine light analogy, my immediate reaction as a patient would be to tell the doctor, no, you're just not looking hard enough. Look at the engine again. You obviously missed the real disease.
Which is an entirely human survival mechanism. I mean, if you are in pain, you almost want a broken bone, because a broken bone makes sense, right?
Yeah, you can put a cat on a broken bone.
Exactly. And this deep-seated resistance is exactly why CHC's model puts a massive emphasis on front-end validation.
So they have to prove they believe the patient first.
Right. If a clinician skips the step of validating the physical reality of the stomach trouble, the patient will immediately reject the psychological diagnosis.
That makes total sense.
And this also illustrates why treatment requires a licensed clinical therapist working directly in tandem with a medical team.
So it can't just be a brush off.
No, it cannot be a dismissive handoff where a primary care doctor just says, well, I can't find anything, go deal with the therapist.
Yeah, go talk out your stomach ache.
Yeah, that doesn't work. It has to be a collaborative circle of care. Ensuring the patient understands that treating the psychological component is actually part of treating the physical pain, not a replacement for medical care.
Because if they feel dismissed, the natural reaction is to just, go find another specialist, order another round of redundant, really expensive tests, and just keep searching for a structural cause that frankly isn't there.
And that search consumes the huge amount of time and energy that is the hallmark symptom of the disorder.
They just get trapped.
Completely trapped in waiting rooms, researching symptoms late into the night, draining whatever minimal energy they even had left to begin with.
Which brings up a massive logistical and, frankly, medical hurdle.
Okay, what's that?
Well, if the physical symptoms are confirmed as real biological events, but the root cause is a hyperactive sensor system, how does a provider actually go about treating it? I mean, a therapist can't write a prescription for an antibiotic to cure a misfiring nervous system.
True.
And a surgeon can't operate on a disproportionate sense of worry.
Right. The treatment paradigm here requires a real shift in the primary objective.
How so?
Well, the CHC framework asserts something really pivotal. They say that while the physical pain is entirely real, the distress is the treatable part.
Ah, okay.
So the clinical focus pivots away from trying to artificially mute the physical sensation, and it zeroes in on dismantling the emotional and psychological panic that surrounds the sensation.
And the mechanics of dismantling that panic rely really heavily on evidence-based cognitive behavioral therapy, or CBT.
Exactly.
The goal of using CBT in this context is to quiet what the clinicians call the anxiety symptom cycle, ultimately improving the patient's daily functioning.
Yes, that cycle is key.
But I want to zero in on how this cycle actually operates on a biological level. Because if the anxiety is treated with therapy, does the physical stomach trouble or the chronic fatigue actually vanish? Or is the patient simply learning how to, grit their teeth and ignore the pain?
That's a great question. The clinical target of evidence-based CBT is not to make the physical symptom instantly vanish, nor is it forcing the patient to just suffer in silence.
Okay, so what is it doing?
The objective is to change the brain's relationship to the physical sensation. Think about the physiological cascade of panic.
Okay.
When a patient with somatic symptom disorder feels a sudden, sharp pain in their stomach, that sensation triggers an immediate, intense psychological reaction. The cognitive leap goes instantly to, this is life-threatening, I am in grave danger.
Right, and that level of catastrophic thinking isn't just a fleeting thought, is it? It's an active biological event.
Oh, absolutely.
Because fear dumps a massive amount of cortisol and adrenaline straight into the bloodstream. It's essentially like pouring gasoline on the physical symptom.
Yes. That flood of stress hormones actively alters the body's physical state. Adrenaline causes immediate muscle tension.
Right.
And cortisol disrupts the smooth muscle tissue in the digestive tract. So the sheer panic of feeling a stomach cramp literally causes the gut to tighten further.
Making the original stomach pain significantly worse.
Exactly. And the worsening pain then serves as biological proof to the brain that the initial catastrophic thought was correct.
Oh, wow. So it proves the fear was justified.
Yep, which triggers more panic, more cortisol, and even more pain.
So the anxiety symptom cycle is basically a self-sustaining engine. The symptom causes the anxiety, and the anxiety amplifies the symptom.
And CBT is designed to jam the gears of that specific engine.
How do they do that?
A therapist works with the patient to intercept the catastrophic thought before it triggers that adrenaline dump. So instead of the brain jumping to, I am in grave danger, the patient learns to cognitively restructure that thought into something neutral and grounded.
Like what?
They learn to tell themselves, I'm experiencing an uncomfortable abdominal sensation, but my medical team has thoroughly evaluated me and I know I am safe.
I see. By neutralizing the thought, you prevent the nervous system from hitting the panic button. You stop the cortisol from flooding the digestive tract in the first place.
Precisely. By lowering the distress, the nervous system finally gets a chance to stand down. And the fascinating byproduct of quieting the anxiety is that the physical symptoms themselves often do decrease in severity.
Because the biological fuel of the panic has been removed from the equation.
Exactly. But the true metric of healing, like the real goal of the therapy here, is reclaiming the massive amount of time and energy previously lost to worry.
Getting their life back.
Yes. If a patient can feel a twinge of pain and continue with their workday instead of spending 4 hours spiraling on medical websites, their daily functioning has profoundly improved.
But, knowing that CBT is effective for this cycle is basically useless if the patient can't actually get into a therapy session.
Oh, absolutely. Access is everything.
Delivering this kind of nuanced collaborative care requires an incredibly robust infrastructure. We are talking about patients who are dealing with profound, bone-deep fatigue and severe chronic pain.
You can't expect someone in that condition to jump through a dozen logistical hoops just to speak to a professional.
No. The best clinical model in the world fails entirely if it is hidden behind insurmountable geographic and financial walls.
Completely agree.
So let's look at how CHC operates as a case study in breaking down those walls. According to their operational framework, the practice operates on a 100% telehealth model, utilizing a high-pay compliant platform.
Which is huge.
Yeah, and what stands out most is their coverage area. They serve all 159 counties in the state of Georgia. They have completely erased the physical map.
And removing that geographic barrier fundamentally changes the patient's baseline stress level before the session even begins.
I would imagine so.
Think about it. If a patient is managing severe chronic fatigue, the physical toll of driving 45 minutes across a busy city, navigating a stressful parking deck, sitting in a sterile waiting room, and then driving back home, that can be the exact reason they abandon treatment altogether.
It's just too much.
It is. A telehealth model brings the clinic directly to the couch. It preserves the patient's very limited physical energy for the actual cognitive work of therapy.
And they aren't just relying on, one or two providers stretched incredibly thin across the entire state. They have built a diverse team of over 15 licensed therapists.
Right, including licensed clinical social workers, professional counselors, and marriage and family therapists.
And their scope goes way beyond just treating somatic symptom disorder, too. They handle individual, couples, family, and teen therapy for anyone 13 and up, plus life coaching.
Which is vital because somatic symptoms rarely exist in a clinical vacuum.
Oh, really?
Yeah, that hyperactive nervous system we talked about earlier, it is frequently the downstream result of other things. Unprocessed trauma, prolonged periods of intense grief, or just chronic grinding stress.
They treat all of that too, right? Anxiety, depression, PTSD, relationships.
Exactly. Furthermore, CHC places a heavy emphasis on maintaining a culturally competent team, which is incredibly important when dealing with somatic complaints.
Okay, I wanted to ask about that. How does cultural competence specifically tie into the manifestation of physical pain? Does the culture a patient grows up in actually change how their body processes distress?
Well, it changes how distress is permitted to be expressed.
Oh, interesting.
In many cultures and communities, psychological pain carries a really heavy, isolating stigma. A patient might come from a background where speaking about depression or anxiety is viewed as a personal failure or even a spiritual weakness.
So they can't just say they're depressed.
Right. In those environments, the brain's only socially acceptable outlet for expressing profound emotional distress is through physical somatic complaints.
Wow.
They might not have the cultural vocabulary to say, I am drowning in grief, but they can say, my chest is unbearably heavy or my back is in agony.
So a culturally competent therapist recognizes those physical complaints as the body's translation of emotional pain.
Exactly. Having a provider who understands that nuance prevents the patient from feeling alienated, which unfortunately is often what happens in traditional medical settings.
That makes perfect sense. The body finds a way to speak, even if the culture forbids the words.
It always does.
But there is another massive barrier we need to look at, which is the mechanism of financial trauma in the healthcare system.
Oh, the financial piece is critical.
Yeah, CHC's model has very specific financial structuring. For Medicaid patients, they offer a $0 copay. And for patients with major commercial insurances like Aetna, Cigna, BCBS, UHC, or Humana, The out-of-pocket cost is kept between $10 and $40 per session.
Structuring a practice to accept Medicaid with a $0 copay is intentionally disruptive to the standard, often exclusionary model of private mental health care.
I want to look at how that financial access directly impacts the biology of the treatment.
That's good.
Because treating highly stigmatized conditions like somatic symptom disorder requires the patient to feel entirely safe. So if you have a patient dealing with an anxiety symptom cycle, how does removing the financial burden, like not having to worry about a massive medical bill, actually change the clinical outcome of the therapy itself?
Well, it honestly dictates whether the therapy can work at all.
Really?
Yes. When a patient logs into a session to dismantle a catastrophic anxiety loop, they need every single ounce of their cognitive resources focused on the therapeutic work.
That makes sense.
If a patient is sitting on their couch listening to a therapist, but their internal monologue is silently panicking about how they are going to afford a $150 out-of-pocket fee for the hour, the clinical work is completely blocked.
Because the financial stress triggers the exact same fight-or-flight cortisol response the therapist is trying to treat.
Exactly.
You would literally be trying to treat anxiety while actively injecting new anxiety into the patient's environment.
It's totally counterproductive. By drastically lowering the financial barrier, CHC is removing a massive environmental stressor. The patient doesn't have to choose between putting gas in their car, buying groceries for the week, or receiving life-changing mental health care.
It creates safety.
It really does. When you eliminate the threat of financial ruin from the equation, you create a stable, secure environment where a hypervigilant nervous system finally feels safe enough to power down. The $0 copay isn't just a billing feature. It is an active component of the clinical treatment.
It is treating the reality of the patient's whole life, rather than just treating an isolated symptom in a vacuum.
Exactly.
And if anyone wants to check out that model, their website is cheattherapy.com. Or you can email them at support@cheattherapy.com, or even call them at 404-832-0102. So to pull all of these threads together for you listening, validating and treating real, distressing physical pain requires so much more than just running another blood panel or ordering another scan.
It really does.
It requires a profound understanding of the mind-body connection. It takes tools like evidence-based CBT to intercept the brain's catastrophic thinking and quiet the physiological feedback loop of distress. But just as importantly, it requires a systemic healthcare model that actually allows you to access a culturally competent professional without geographic strain or the looming threat of financial trauma.
The overarching takeaway from exploring this clinical model is a fundamental message of validation for the patient.
Which is so needed.
It really is. If you are experiencing this, if your body is sounding relentless alarms, if your fatigue is crushing, your pain is real, but your diagnostic tests just keep coming back clear, you are not crazy.
No, you aren't.
You are not making it up for attention, and you are not faking your suffering. You deserve a medical and psychological team that fundamentally believes you, and you deserve comprehensive help to reclaim your daily life.
The pain you are feeling is real, and the path forward is real too. And that leaves us with a final, slightly provocative thought for you to mull over today as we wrap up.
Okay, what is it?
Well, we've spent this deep dive exploring severe, clinically diagnosed somatic symptom disorder. But the mind-body connection isn't a binary switch. It exists on a spectrum that all of us experience.
Oh, absolutely. Every single human nervous system operates on this spectrum.
So if identifying and treating psychological distress can genuinely improve physical functioning in severe cases like chronic fatigue or debilitating stomach trouble, how much of our own everyday run-of-the-mill physical discomfort is actually a psychological signal?
That is a great question.
Think about that brutal tension headache you get after a combative meeting, or that inexplicable knot in your stomach on a Sunday night before a stressful work week. How often might our everyday physical pain just be our minds asking us for a little emotional support?
Probably more often than we think.
Maybe the next time the check engine light comes on your own body, before you start tearing apart the engine looking for a broken part, you should take a moment to check in with the driver.